Good morning, good afternoon, good evening, good night, depending on wherever you are in the world at the moment. So welcome to the joint session of the Nurses Network and Supportive Care Network. This is a live joint session. The topic is the pandemic and pediatric oncology. The pandemic has affected everyone in the world, also has affected pediatric oncology. And we will be discussing the miscare and challenges in pediatric oncology during the pandemic with our very distinguished guests. I am Rejin Kebudi, a professor in pediatric hematology oncology in the Istanbul University Oncology Institute in Istanbul, Turkey. And I'm also the co-chair of the supportive care group, the Support Care Network of SIOP. And I will invite my co-chair, Courtney Sullivan, to introduce herself, or let me first introduce her, and then she will introduce the first speaker. In fact, let me give a little brief information about this session. We'll have three subtopics. One will be on the miscare and challenges in delivering nursing care in pediatric populations in the pandemic. Then we will be talking about the global outcomes and challenges in pediatric oncology during the pandemic. We will give examples of some nationwide studies in the pandemic that is about the pediatric cancer and COVID-19. And also we will be giving the results of the global SIOP and St. Jude Global Registry of the COVID-19 pandemic in pediatric cancer. And then we will talk about the moral distress among healthcare professionals. So be ready for a very, very important and interactive session. Now I'd like to introduce my co-chair, Courtney Sullivan. Dr. Sullivan is presently a postdoctoral research fellow at the University of Alabama at Birmingham. Dr. Sullivan has worked with Nurses International for nearly a decade, implementing subspecialty education programs, multi-site quality improvement projects, and measuring and advocating for nursing standards in mainly low and middle income countries. She's, as I said, at the moment at the University of Alabama at Birmingham. Her research focuses on developing a core set of nursing sensitive quality indicators for pediatric oncology internationally. Dr. Sullivan is actively involved in several SIOP committee and working groups and is incoming chair of the SIOP Nursing Network. So with this, Courtney, I invite you as my co-chair, please.
Thank you so much, Dr. Kebudi. And I would also like to welcome you to this session. So we have the pleasure of introducing our first presenter, Dr. Heather Tubbs Cooley, who is an associate professor at the Ohio State University Colleges of Nursing and Medicine and principal investigator of the Center for Perinatal Research at Nationwide Children's Hospital. She received her BS in nursing from Western Michigan University and PhD from the University of Pennsylvania, and completed a postdoctoral fellowship in quality improvement and implementation science at Cincinnati Children's Hospital in 2013. Dr. Tubbs Cooley's research focuses on understanding factors that both impede and enhance the quality and reliable delivery of core nursing care in neonatal and pediatric settings, with a goal of redesigning systems to better support the critical work of frontline clinicians. By combining classical health services research approaches with emerging methods such as intensive longitudinal matching of data from nurses and patients, Dr. Tubbs Cooley and her team are discovering new insights about patterns of nursing care delivery that impact patient outcomes. Her work has been funded by the NIH, the Agency for Healthcare Research and Quality, and the American Nurses Foundation, and featured by the New York Times, Medscape, and National Public Radio in the United States. Thank you, Dr. Tubbs Cooley.
Thank you, Courtney, for the introduction. Before I begin, I just want to make sure that everyone can hear me okay. I think you can. I'm sure I'll get feedback if you cannot. I'm going to go ahead and share my slides. It's wonderful to be with everyone today. Let me get these slides open here. All right. I was asked to give a pandemic update on missed nursing care in pediatrics. And I need to give you full disclosure. I am a pediatric nurse. I'm not an oncology nurse. I'm not a pediatric oncology nurse. However, the majority of my research does focus on missed nursing care in pediatrics, and certainly the pandemic is really been a window for worldwide for the public, for other clinicians, for many people to understand just how important nursing care is and just how what an impact nursing care has on patients and what happens when nurses can't deliver care in the way that we need to be delivering it. So again, I really appreciate the opportunity to speak today. I have a couple of objectives for this talk. So what I'd like to do is review pre-pandemic science on nursing care, missed nursing care in pediatrics and pediatric oncology, discuss the impact of the pandemic on nursing care delivery. Many of you are living this in your everyday work, so you probably don't need to hear it from me, but I do think that there are broader themes that we are hearing across different types of nurses all over the world about how this pandemic is influencing nurses and the way that they're able to deliver care. And then offer some considerations for future work on missed care, specifically in pediatric oncology, for those of you who may be interested in research, nurses who are really interested in this topic. I'm going to offer you some specific considerations and a blueprint for how to maybe move forward with this work in peds oncology particularly. So this is an integrative review that myself and a few others published last year. So this is very recent. When we talk about missed nursing care, what we mean by that is it's necessary care or essential care that's delayed, incomplete, or left undone during an actual shift. This has been a topic that's gotten a lot of attention globally. Most of the research on missed nursing care is centered in adult populations, such as adult critical care, adult mid-surgical care. There's unfortunately, and this is sort of where the bubble bursts. There is unfortunately not much research on missed care in pediatric and neonatal settings, inclusive of pediatric oncology. So this review that we did last year, it's pretty encompassing. I encourage, if you're interested in the topic, go take a look. But when we think about missed nursing care in pediatrics, I'm just going to walk you through, of the studies that we do have, I'm going to walk you through what we know about what gets missed, what we know about patterns that we see, and give you a sense of the type of research we currently have and where we need to be going next. So when we think about missed nursing care in pediatrics and papers that focus on just, kind of a broad survey of pediatric care, there is only one study, unfortunately. This is a study from 2017. It's a sample of about 2,000 nurses in NICU, PICU, and also general acute care. So this is not pediatric oncology focused, unfortunately. What we know from this study is that more than 50%, and of course this is pre-pandemic, all of this evidence is pre-pandemic, so that in pre-pandemic times, we know that greater than half of nurses reported missing at least one essential care item on their last shift for their pediatric patients. The things that get missed or that were reported missed most frequently were developing care plans, updating the plans of care, comforting and talking with patients and their families, doing needed teaching so that families and kids could go home on schedule, documenting care, and then again, preparing that patient and family to get ready for the discharge. So that it's a very high level, broad strokes. Mostly, this is a descriptive paper, just kind of laying out the landscape for what this looks like in pediatric environments. Now, pediatric nursing or neonatal care. This is where the majority of the work is focused with respect to missed nursing care. There are 8 studies, and actually happy to, I will provide a reference list of these. I didn't want to include them all on the slide, but just to tell you, we have comparatively more in neonatology, but we only have 8 studies, empirical database studies. These studies and really these 8 papers, these 8 studies are mostly done by 2 teams of researchers, my team and another team from the University of Pennsylvania. And we do complementary work with different approaches, but we all capture self-report from nurses. So we are trying to hear from nurses themselves about what is it that you needed to do for your patients, but that you didn't have the opportunity, you couldn't get to during your shift. From these studies, we consistently see that staffing ratios, patient acuity metrics, and other workload metrics are really strongly associated with increased reports of missed care. That's consistent also with the adult literature, where workload is really heavily influential. It's not the only thing that influences missed care, of course. We know that there are some individual level, within individual characteristics that have an influence. We know that dynamics like teamwork seem to matter as well, but we don't have a good pulse on those in pediatric care. Missed nursing care is also associated with worse infant outcomes, including outcomes such as delayed time to achieve full oral feedings, which then delays length of stay, and also healthcare acquired infections. We also have some early evidence that this is a health equity issue. There's at least one paper showing that preterm infants in majority Black serving NICUs have more exposure to missed nursing care through potentially higher workloads of the nurses who are working in those institutions. And so when we start thinking about health equity, we do see that there are populations of infants that may be more at risk for experiencing miscarriage, and they're thereby at higher risk potentially for worse outcomes because of the missing of the care that they might be missing. So it's something that our team is certainly thinking about a lot more, and thinking about what do we how do we better understand that, and what do we do about it. I think it's important to point out that no studies focus on intervention testing at all in miscarriage. I think I'm pretty confident, I think I'm in solid ground to say at all in all of the miscarriage literature and miscarriage research, this work is really correlational or quasi-experimental with no prospective testing of interventions to address miscarriage. So that's something that we're working toward for the future for our next work, is getting to interventions. And then since we're on neonatology, just want to talk a little bit about, we have a study right now that's funded by the National Institutes of Health looking at missed nursing care. We call this care reliability, just a little turn of phrase, to be honest with you, because there's the term missed care seems to be bothersome or doesn't sit well with some people. So we frame this now as high reliability care. So in our study where we enroll, it's a multi-NICU study, we enroll nurses as human subjects. We ask them to report longitudinally with repeated measures over 12 months about care that they've missed for individual infants. And then we match that up with infant electronic health record data. So we get both a self-report, we also get electronic health record documentation to see if these match up. And then we also look at outcomes. So we're looking at 3 metrics of workload. We're looking at, of course, ratios. We're looking at acuity scoring tools and whether that's associated with care reliability. And then we also, our team looks at subjective workload using a validated tool. Nurses' own subjective experiences of workload during a shift. Actually, in our prior work, we find that is most predictive of missed care. So even though the objective metrics might look okay, that sometimes doesn't match up with the felt experience of workload, and that does seem to influence performance. And that seems actually really logical to us. And so some of our next work is focusing on how do we address subjective workload. Something that we're trying with our study, we actually, COVID forced us to pivot to do remote data collection. So we have nurses who download an app. These middle and left, right side, these are our tools that are within our app. So nurses are using their cell phones to report to us at the end of shifts. We text message them, that's how we communicate. And we think that this is actually a really scalable model for this kind of research that, across many institutions, this would be a way especially in pediatric oncology, where you may not have, huge units per institution where you really need to do multi-institutional studies. The methods and the way that we're doing this actually would scale very nicely to an environment like pediatric oncology. All right, so let's get to pediatric oncology. There's one study that was just published, I think in August of this year, that focused on fatigue and care rationing. Care rationing is another term. It's often considered synonymous with miscare, but there are some conceptual differences. But for the sake of this paper, we're going to kind of call them conceptually almost the same. This was conducted in Poland. And again, descriptive study looking at what nurses most frequently missed or ration, again, patient monitoring, addressing needs of newly admitted patients, documentation, then that communication and support piece again. So this is really where you are in the field with understanding miscare in pediatric oncology. I think this was a sample of 95 nurses. Certainly, room to grow here for your field. So if I could summarize the evidence for you just with a big picture in pediatrics, this work is mostly descriptive and correlational. Of course, most of it's done in the NICU. Workload's a big contributor, but other factors matter. And I'm going to talk about this, about workload coming back to the pandemic here in a minute. We think this is a health equity issue. I think if we were looking more closely, we might be seeing patterns that might concern us. Now, certainly, we don't know whether nurses are intentionally, differentially missing care for different infants. I highly doubt that's, of course, the case. But certainly different environments seem to predispose nurses to be more likely to miss care for different groups of infants. And I think that's an important area to focus on in the future. And we don't have any interventions, and that's always a real limitation because it's important, we're describing the problem, but we have to get to a point where we can start trying things to fix it. So if I could give you a blueprint here for, taking some cues from the way that this work has proceeded in other areas. Give me 1 second here. I'm going to move something around. Here's what I would recommend. There's sort of a sequence here, and you don't have to start at the beginning, but it's really important that pediatric oncology nurses define specific aspects of care that are essential for most pediatric oncology patients. A criticism that I have of some of the miscare work is that there are tools out there that are used that are very general, like there's one, the miscare survey. We pattern our questions after the miscare survey, but we tailored them to be very specific to neonatal care. I think that that's really important for pediatric oncology to have specific identifiable aspects of care that are really critical for best oncology outcomes in your patients. So defining those as a step. Establishing the baseline prevalence of those is a step, and one that can be done pretty quickly. It's really debatable whether it's necessary to formally empirically make the linkage between miscare and outcomes. I think we know from existing literature that when care doesn't happen, and a lot of this evidence has come from QI work, that when things don't get done, certain things that it increases infection rates or it increases mortality. So I think that you could probably pass by the middle step, although it's good to establish that evidence, but not necessarily as a key focus. understanding the contributing factors and the causal pathways. This is really where I think a really important place to focus, because it's difficult to fix things if you don't understand the mechanisms of what's contributing. And so if we can understand that, then we can get to the development and testing of interventions. And this is really where, from a pandemic perspective, we have problems to fix across the board in nursing with respect to miscare. All right, now COVID. What we know across the globe and across all kinds of groups of nurses is that workload is up and miscare is up. And this is just one article that I really like that really talks specifically about the impact of workload on actually being able to deliver high quality nursing care. They frame it as pandemic burnout, but if you really read it, and there are lots of other great papers, articles, globally about this phenomenon, but this is what we have right now. Our investigative journalism reports, or just journalism reports. We have a lot of nurses on social media talking about the impact of high workload on their ability to not just get care done, but to even cope with the demands that they're facing. So when it comes to evidence about what's going on with miscare and the evidence we have in the context of the pandemic, I think right now we have a lot of good, I'm still going to call it evidence. I think nurses telling us social media and telling us their stories is still an important way of conveying what's going on. And so I'm not going to discount that at all. We don't have academic, if you will, evidence yet, but I think that we will. Here's what we're finding with the impacts of COVID on the ability to actually understand miscare during the pandemic. We're doing our study we started this study in March of 2020, right when the pandemic started, in our NICU study. And so all we have are data on workload and miscare during the pandemic. I'm not sure if that's going to be a great data for extrapolation to normal times, but I also don't know what normal times, whether and if we're going back to normal times in terms of workload. There's a lot lower enthusiasm among hospitals to participate in this kind of research and or disclose information about workload, as you can imagine. We, really rely on hospitals to be good partners, to allow us access to their nurses, allow us access to their health record data. And that's been a real challenge, is that this is not something that hospitals really want to tell about. There's a lot of nurse attrition. High attrition in our study, nurse attrition due to nurse turnover. I'm not sure if other countries are experiencing the degree of healthcare worker turnover as we are in the United States, but our study, we are having constant dropout because people keep leaving their jobs. It's more difficult to recruit nurses into studies right now because people are tired and they don't want to be asked to do one more thing, and I completely understand it. Importantly, there's a nurse tolerance for non-intervention research on this particular topic is very low. So when we approach and say we're trying to understand what contributes and the degree to which workload contributes to miscare, they're like, I can tell you right now it does. I can tell you right now that it's a key driver. And so I really want to know that you're going to do more than just show this relationship and publish a paper. I want you to actually fix the problem. And so I think that's a really important point for academic, people to be focused on getting quickly to interventions because people need help. And then it's been, of course, very difficult for in-person research teams to get into these environments and create those relationships with nurses, which just exacerbates all of the other issues that we're having. I will say that big data approaches to this topic may be helpful, would be helpful. And I think I'm It's not for this talk, but we're also working on that. So what do you do? I'm closing up here. What do we do about miscarriage? Do we do more QI? Do we ask nurses to, do more checklists, put more things on their plate to say, now we're going to implement a checklist for this, that, and the other? Is that the answer? Do we focus at the individual level and say, well, we just need to build your resilience to, higher workload, or, maybe do some wellness stuff, and I'm not discounting that at all, but is it really appropriate at the individual level to intervene there? Do we need better policy solutions such as, caps on workload? Or are there other things that we should be considering? And so I'm going to leave you with some parting thoughts. Miscare patterns are very similar across settings, and I don't think that pediatric oncology is going to be an exception to that. That's just my gut hunch. I would challenge you to think about what are required tasks that oncology nurses are doing that add little or no value for patients and families. And then when we think about those, how do you convince leaders and maybe nurses themselves to de-implement things that are low value with respect to oncology care? How do we halt this pattern of adding work constantly to nurses but never removing? I think that's really going to, have to change. And then how do we better manage workload in this pandemic and post-pandemic environment? I think all bets are off in terms of how that's going to work out. And I'm going to stop there.
Thank you so much, Dr. Heather. Well, yeah. I would like to share the screen while Courtney, you introduce us.
Thank you. That was an excellent presentation.
Yeah, that was excellent, right?
So I have the pleasure of introducing our next speaker, one of them. Dr. Rejin Kebudi is a professor in pediatric hematology oncology and chair of Department of Preventative Oncology at the Istanbul University Oncology Institute. She is co-chair of the International Society of Pediatric Oncology Supportive Care Working Group and is the recipient of the American Society of Clinical Oncology 2018 International Women Who Conquer Cancer Mentorship Award. She is an active member of many major international oncology societies such as SIOP and ASCO, and her research interests include biology and clinical management of pediatric cancer, supportive care, cancer predisposition syndromes, cancer care in developing countries, and pediatric cancer in crisis.
Thank you, Courtney, for the introduction. Dear Chairperson and dear colleagues and participants, I'd like to give a brief overview of the global outcomes and challenges in pediatric oncology during the pandemic. As of this week, as you know, there has been about 250 million people infected with COVID worldwide and about 5 million deaths due to COVID. Adults with cancer have a higher risk for COVID infection and more severe disease and mortality. Although children seem to be at a lower risk for COVID-19 than adults, children with cancer are at increased risk, especially when compared with their healthy peers. For example, the severe and critical disease in many studies is about 20%, whereas it's about 1% or even lower in healthy children. The mortality due to COVID is around 2 to 10% according to studies due to COVID in pediatric cancer, whereas it's about 0.04% in the healthy pediatric population. After the pandemic was announced, the SIOP, Centered Global, COG, and many related oncology groups have come together, and we had wrote a rapid global response for children with cancer, so to guide the healthcare professionals that are dealing with pediatric cancer, which has been quite helpful. And also there has been other publications on the consequences for children with cancer that we have wrote with our colleagues in St. Jude and also Latin America. There has been also many studies that were conducted as single centers, multi-centers, nationwide studies like the ones that I will be presenting now, that we did 2 nationwide studies in Turkey, and also the global registry of COVID-19 in childhood cancer, which Dr. Sheena Mukkada will be presenting after my talk. Well, infection with the virus is not the only threat to children with cancer. The pandemic has interrupted and slowed down several health services. And the interruption and delay in treatment for children with cancer, especially in those who are at the first months of treatment and have not achieved remission yet, has been a major problem. Treatment interruptions, treatment delays have been reported in 50 to 60% of the patients in many adults and pediatric studies. For example, in the pediatric study nationwide that we did in Turkey, there was a delay in treatment due to COVID in about 63% of the patients, with a median of 15 days up to 45 days. And in fact, 12% of these patients were just at diagnosis. And in the global registry, almost half of the patients had some treatment alterations due to COVID. Well, there has been also many big surveys that were done in Latin America, Middle East, North Africa, West Asia, and globally. One of these that was done in Latin America, a survey in 20 countries with 453 pediatric oncologists participating, has reported that the impact was higher in countries with lower healthcare expenditures. The COVID-Impact study that was done in 213 institutions in 79 countries, and 63 of the institutions were in low and middle income countries, has found that the low and middle income countries, the centers in low and middle income countries, have been affected more than even the other centers in high income countries. In fact, of note, it was reported that 1/3 of the centers reported that the numbers of patients abandoning treatment, which is really very a threat to pediatric oncology, has had risen up in these 1/3 of the centers. 43% of the centers had fewer new cancer diagnoses than expected. 7% had reported complete closure of their pediatric hematology oncology services. The impact of COVID has been also on academic system and scientific research as well. The impact in economy has been seen in many, in pediatric oncology, also in many other subjects. Many parents and caregivers of children with cancer also have lost their jobs. And in fact, they had some hard time during this time, which is always so hard because of the pandemic anyway. And the psychological effects have been a lot. Anxiety, depression, post-traumatic stress, burnout syndrome have been seen in many in patients, in parents, but also in the healthcare professionals. And it has been reported that women and nurses have been the most affected psychologically. And research funding has decreased. In 2 reports from developing countries, it was shown that that is from the United States, Canada, European Union, that $100 to $365 million of shortfall was because of the fund, because the funding had decreased to that extent in many Western developed countries. And the prediction was that there was a $9.5 billion shortfall in the next 6 years, which is a threat to scientific advancement of early diagnosis, treatment, and cure, both in adults and in children. Well, with this, I would like to summarize the study that we have done. This was a nationwide study in Turkey with the support of the Turkish Pediatric Oncology Group Society and the Pediatric Hematology Oncology Society. The aim was to see, to evaluate the children with cancer who had COVID infection, with the aim to see the impact of COVID-19 on cancer treatment in children, which subgroups of childhood cancer were at higher risk for severity, mortality, and complications, and were there any clinical radiological lab parameters to identify these patients at higher risk. What we did that is, in the first study, we had evaluated all the children that had COVID cancer and COVID-19 infection in the first 3 months of the pandemic. That's in the first wave. So there were 24 centers and 51 patients, and this covered almost 100% of all the patients in that time limit in Turkey with cancer and COVID-19. And we have seen that the median age was 6 years. The male-female ratio was 1.8. So there were males were a little more than females. Half of the patients had a diagnosis of leukemia, 60% had leukemia and lymphoma combined, and 40% other solid tumors, and 12% were just at the beginning at diagnosis when they had the COVID infection. And also, we saw that there were 12% who had stem cell transplantation. 78% of the patients had a confirmed diagnosis with PCR, and 22 had a possible diagnosis according to the WHO, the World Health Organization criteria. Almost half of the patients had a history of COVID contact with a person in the family or with a caregiver. Most common presenting signs were fever and cough, and the most involved site was the respiratory system, followed by the gastrointestinal, CNS, musculoskeletal system, and the skin. In the first months of the pandemic, each child had, most of them had a chest CT also, and there was a pathology in 51% of the radiological findings. And 30% of the patients were admitted with febrile neutropenia and were diagnosed with COVID as well. According to disease severity, 49% were asymptomatic or mild, 29% were moderate, 4% were severe, and 18% had critical disease. Just to remind that the severe were the ones that need the higher level of care or need for oxygen greater than a face mask or nasal cannula, but not intubation. And the critical ones had organ dysfunction, intubation, or death due to COVID-19. The mortality was 2%. There was one death among this cohort, and the mortality was 2%. The delay in chemotherapy or other treatment was seen in 63% of the patients, with a median of 15 days ranging to 45 days. Prognostic factors for a critical disease were having a hematological malignancy, having had a transplantation, a mixed infection, or radiological findings in the chest CT. After this first study, we continued to monitor and to evaluate the patients again, and we tried to see what had happened after this first wave. And in this second study, 25 centers participated with 180 patients. This was also supported by the Turkish Pediatric Oncology Group and the Turkish Pediatric Hematology Societies. And the results of this study will also be presented in the poster discussion session on Sunday at 12:30. Well, the median age was 7.6 years. The range was from 3 months to 18 years. There were more males, and 50% were diagnosed with leukemia, lymphoma, and the other 50% with other solid tumors of all kinds. And 8% had stem cell transplantation. The severe and critical disease was 14% in this cohort. It was 22% in the previous cohort, and it was 14% in this cohort. And there was a contact history in a family of infection in the family or the caregiver in 58%. 94% of the patients were all PCR confirmed. The respiratory system was again the mostly involved organ or system. The follow-up of these patients was almost 5 months. The least was 1 month. Of note, in this cohort, we have 10 multi-inflammatory system in children, the MIS-C syndrome. I will tell a little more about that in a few minutes. There were treatment interruption in half of the patients, as mostly delays in treatment. The PCR positivity lasted about 15 days median, going up to 90 days even. 14% were in the ICU, 8% were intubated, and the mortality was 4%, higher than the first wave. Radiology, there were radiological abnormalities in 45% of the patients who had a radiological imaging. And in the lab, especially in the critical patients and in the MIS-C patients, the multi-inflammatory system in children, the dimer and interleukin-6 levels were quite high, and the ferritin levels. So we had 18% severe and critical, and among these, we had the multi-inflammatory system in children, and 4% mortality. Prognostic factors, for critical disease were neutropenia, mixed infection, radiological findings in chest CT, and having had a transplantation. We had 10 cases with multi-inflammatory system in children. 5 of these were leukemias, and 5 of these were solid tumors. 4 of these died, unfortunately. 1 was a leukemia patient at induction. 1 was a neuroblastoma patient just at diagnosis. 1 was a hepatocellular carcinoma at relapse and refractory disease. The germ cell tumor patient was at the end of treatment in remission and unfortunately had died of the multi-inflammatory system in children. And you can see some of the skin findings. In conclusion, children with cancer are at a higher risk for severe critical COVID-19 infection in comparison to children in the general population. Children with hematological malignancies, those who have had a stem cell transplant, those who have mixed infections seem to be at a higher risk, and also those who have a radiological abnormality in the chest CT, in the ones that do have an imaging. The COVID-19 pandemic has caused an interruption and slowdown in several health services and has reduced funding for research in cancer. Evaluation and sharing of national and international data of children with cancer, transplantation, and COVID-19 leads to a better understanding of the disease, treatment, and risk factors to guide healthcare professionals. Whether the negative impact of the COVID-19 pandemic on healthcare services will affect survival rates of children with cancer globally in the coming years should be monitored by epidemiological research, and action should be planned urgently for prevention and recovery. You know, we are aiming the WHO and the SIOP to have at least 60% of survival in the 6 most commonly seen cancers worldwide, also in the low and middle income countries. And we don't want COVID-19 pandemic to have a negative impact on this good hope. Well, we shall also emphasize that the safest way to effectively and sustainably prevent COVID-19 in a society is to have an effective and safe vaccine and to successfully vaccinate the majority of the population. As you know, COVID-19 vaccines are recommended for all children more than 12 years of age, especially if they have an underlying medical problem, such as cancer. And also, don't forget, we have to recommend that their caregivers and household contacts have to be vaccinated and protected from the infection. In a very nice study done in New York in Memorial Sloan Cancer Center, it was seen that the caregivers who had no symptoms and no contact with the infection tested positive with PCR. 15% of them tested positive. So we have to protect our children. Also, the caregivers and the families have to be protected, and the general population have to be protected if we want to protect all of our children from the COVID-19. And with this, I will end my talk, and I would like to thank the Turkish Pediatric Oncology Group, the Turkish Pediatric Hematology Society, all our colleagues that have collaborated in these studies and also in the coming study, because we are still going on with this study and we have now 287 patients, in fact, especially Dr. Deniz Tukcu and Dr. Nilgün Kurucu, with whom we have analyzed all the data together, and each doctor that has worked with these patients in the healthcare in this pandemic. And also I would like to thank SIOP and Centered Global for taking the lead and providing so valuable information to guide all these healthcare professionals in the pandemic, so that to help our children with cancer. Thank you. Now with this, I end my talk, and I would like to invite Dr. Sheena Mukkada to give her talk. I would like to introduce her also. Dr. Sheena Mukkada is a pediatric infectious disease specialist who is currently an assistant member in the Department of Global Pediatric Medicine with a secondary appointment in the Department of Infectious Diseases at St. Jude Children's Research Hospital. She has completed her undergraduate training at Brown University and MD at the University of Cincinnati, and then has also worked she did her pediatric residency in Children's Hospital Los Angeles and completed her fellowship in pediatric infectious disease in the St. Jude Children's Research Hospital, University of Tennessee program. And her primary research focus is on the development and evaluation of resource-appropriate strategies for diagnosing and treating infection in pediatric oncology patients in resource-limited settings. And also she has worked in this global COVID-19 registry and analyzed all the cases with the collaborators, and she's the first author of the publication that appeared in Lancet Oncology. Dr. Sheena Mukkada, I would like to invite you to give your talk.
Thank you very much. And thank you for inviting me to be a part of this session. So I have the pleasure of presenting the global panorama from the global registry of COVID-19 and childhood cancer. Just want to highlight that this is part of a community response to COVID-19 that was coordinated by St. Jude in collaboration with SIOP that had really a three-part process, which was the Observatory and Resource Center for Childhood Cancer, which you can find at the web link below, covid19childhoodcancer.org. There is one part of this that is a resource library that is a curated resource for a series of publications, guidelines, presentations, information that is thought to be of relevance to providers for care for childhood cancer, specific to the COVID-19 pandemic. There's also a collaboration space, which is an area for providers to share their questions, their anecdotes, their responses, their reactions to literature, and just an opportunity for the community to come together. And the third part of that is where I'm going to spend the most time, which is the COVID registry. Overall, this resource center has logged over 70,000 page views from 164 countries. Now, as I focus on the registry, this really came together out of a need for data-driven answers. The questions that we tackle here are subgroups of childhood cancer patients at higher risk for complications due to COVID-19? And if so, are there clinical or laboratory parameters that might characterize those patients who are at higher risk for complications so that we can prioritize any limited resources in the area of supportive care, vaccinations, antivirals, et cetera? And ultimately, is the delivery of cancer-directed therapy being impacted by COVID-19? The key outputs of the registry are first and foremost a dynamic data visualization, which is updated in near real time. It was really our interest as organizers that the data put into the registry should not just live in a study, but should be at the hands of the professionals who needed to use that data to inform their care decisions with the best knowledge that they had. We also, of course, wanted to create for the community a collaborative publication or collaborative publications, and ultimately to leave the scientific community with open access data sets that they could use to further knowledge. This is a screenshot of the dynamic data visualization that I mentioned. As of this morning, there were 1,775 cases logged from 51 different countries. You can see them here. If you want to explore this visualization, you can click on the countries of interest or filter by the diagnoses of interest and really use the data that is at your hand. So I encourage you to do that so that you can make best use of this resource. We also wanted to create a collaborative publication that was representative of the population of interest. And we did this by creating a data repository of de-identified data that is housed in a REDCap environment. We collect limited key variables pertaining to the diagnosis of COVID-19, as well as the oncologic diagnosis, with a few limited bits of information about symptoms. And later at 30 days, we asked for more information about the course of the hospitalization, if it occurred, in terms of the COVID management, in terms of the outcomes for cancer-directed therapy, whether that was interrupted at all. We also asked for 60-day outcomes for patients without a documented clinical or laboratory resolution of their symptoms at 30 days. The inclusion criteria are being a patient under 19 years of age with a known oncologic diagnosis or receipt of a hematopoietic stem cell transplant and a laboratory-confirmed SARS-CoV-2 infection. This we knew would limit participation by centers that made clinical diagnoses of SARS-CoV-2 infection. However, we wanted to have a very clear and clean data set that did not have any confounding by respiratory viral infections that might otherwise look like COVID. Respondents were requested to upload all institutional cases meeting inclusion criteria. And this is important because otherwise our system of voluntary reporters might just report the cases that were the most memorable or the most severe. And we really wanted to get an idea of what the overall profile of COVID-19 looked like in this population. This resulted in the publication that you see here. We are very excited that this collaboration was able to produce a Lancet Oncology publication at the end of August. And this was really the work of the group of investigators that you see here. These are just the co-authors, but we know that everyone on this slide was supported by a team of nurses, a team of multidisciplinary specialists that contributed all of this work. For the registry's reported data here in the manuscript, the median age was 8 years. We had a predominance of male patients. Half of our patients had acute lymphoblastic leukemia or lymphoma, with another quarter having solid tumors. 83% of all patients were receiving cancer-directed therapy at the time of their COVID-19 diagnosis. And in this overall population, we had a very low number of patients who had received a stem cell transplant, so only 5% of all patients in the registry. In terms of geographic location and World Bank classification, we had very few cases contributed by low-income countries. That may have been partially because of workload, partially because of diagnosis confirmation, but the predominance of our cases were from upper middle income countries, and most of our cases, or the majority of our cases, I should say, by region, 56.5% of cases were contributed by the Americas. And as you can see, there is definitely underrepresentation from certain World Health Organization regions, including the African region, WIPRO, and the Southeast Asian area. In terms of hospital resource use, 67% of all patients incorporated in the registry were hospitalized during their COVID-19 diagnoses. However, 80% of those patients were hospitalized for less than or equal to 30 days. It's important to note that the question is just, were they hospitalized, not were they hospitalized because of their COVID-19 diagnosis. 17% of all of these patients were admitted to a higher level of care. And we have already seen a little bit of the severity grading scale, but I'm going to introduce it here as a composite of clinically relevant outcomes that we created to incorporate resource utilization, the objective measures of organ dysfunction, and staging of respiratory infections, such that a lower respiratory tract infection was judged as being more severe than an upper respiratory tract infection. An asymptomatic infection was a positive test only. A mild infection was confined to the upper respiratory tract with no additional support needed. A moderate infection was a lower respiratory tract infection or an oxygen requirement up to a nasal cannula or face mask. A severe infection was a need for a higher level of care for any reason at all, or a need for oxygen greater than nasal cannula or face mask, but less than intubation. And a critical infection was documented organ dysfunction, need for intubation, or death due to COVID-19. What we found was that severe disease, shown here as the bluish purple critical and the red severe, was documented in nearly 20% of all patients reported to the registry. When we broke this down by diagnosis, not surprisingly, you can see that the largest total number of severe and critical cases was contributed by the diagnoses of acute lymphoblastic leukemia or acute lymphoblastic lymphoma, who also made up the majority of patients contributed to the registry overall. However, when you break down the proportion of patients who had the disease severity as critical or severe, again, boxed in the dark blue, purple, and the red, you can see that by proportions, the patients who had hematological malignancies also had the largest number of these severe and critical outcomes. When we look at patient outcomes at their final follow-up, 87% had either a clinical or laboratory resolution of their COVID-19 infection. And 4%, 3.8% to be precise, had a death that was documented as being due to COVID-19. In terms of outcomes for cancer-directed therapy, if you look at the chemotherapy doses that were reduced, you see that 7.3% of patients receiving active therapy had at least one dose of chemotherapy reduced. In terms of chemotherapy being withheld, that occurred at least one dose or one instance in 44.6% of all patients who were receiving active therapy. When we did a multivariate analysis looking at disease severity, we built a model that incorporated primary oncologic diagnosis, age, absolute neutrophil count, absolute lymphocyte count, the presence of one or more comorbidities, and treatment intensity, which was dichotomized into yes and no. And we'll mention that in a minute. Disease severity for these purposes was collapsed into two levels: asymptomatic, mild, and moderate versus patients who had severe or critical disease. And that, we think, differentiated a population who had very important clinical and just resource needs. Patients who were receiving intensive treatment were basically the patients, as you can see here, who had hematologic malignancies, except for Hodgkin lymphoma, who were less than 30 days from autologous hematopoietic stem cell transplant or less than 100 days from allogeneic hematopoietic stem cell transplant. And in terms of our outcomes, what we found is that patients aged 15 to 18 years had 1.6 odds of severe or critical disease compared to the reference population who were aged 1 to 9 years. Those with an absolute lymphocyte count less than or equal to 300 had 2.5 odds of those severe or critical outcomes compared to those who had an ALC above 300. And patients who had an ANC, an absolute neutrophil count, below or equal to 500 had 1.8 odds of the severe or critical outcome compared to those who had an ANC greater than 500. Patients receiving intensive treatment had 1.8 odds of a severe or critical outcome. And interestingly, when we look at factors beyond the biologic, we could see that patients treated in an upper middle income country had 1.5 odds of severe or critical disease compared to those treated in high income countries. And that odds ratio went up to 5.8 in patients treated in low income countries and low middle income countries in terms of having a severe or critical outcome compared to high income countries. When we looked at treatment modification defined as chemotherapy reduced, chemotherapy withheld, radiation therapy delayed, and or surgery delayed, with the final model that incorporated oncologic diagnosis, absolute lymphocyte count, the presence of at least one comorbidity, the presence of COVID-19 symptoms, and World Bank income level, what we saw is that the indications for who therapy had a modification in wasn't always in agreement with who had the most severe disease, so that the therapy was less likely, we'll say, to be modified in patients who had other hematologic malignancies other than acute lymphoblastic leukemia and lymphoblastic lymphoma, and that patients in upper middle income countries were less likely to experience treatment modification. And again, there are reasons that go into the calculation of why clinicians modify therapy, but this study was not set up to collect those. We saw, not surprisingly perhaps, that the treatments were more frequently modified in the presence of a comorbidity and in the presence of symptoms, as you can see here. And in conclusion for this, there are certain groups of pediatric oncology patients who do seem to be at higher risk for severe or critical outcomes. And those risk factors are both biologic, meaning relating to lymphocyte count, neutrophil count, treatment intensity, and not, specifically that variable relating to country income status. We also saw that treatment interruptions are frequent and don't necessarily align with identifying the patients who are at greatest risk for disease severity, and that overall, as has just been stated, the impact on survival of all of these changes is not yet clear. The registry does remain open, and it's been updated with new data fields to incorporate most recently vaccines, with the exciting introduction of vaccines to the pediatric population that we hope will even expand beyond the age of 12. And now with increased language support to support our global collaborators in French, in Portuguese, in Russian, and in Spanish. I would finish by acknowledging a huge team at St. Jude, as well as at SIOP, who came together to organize these resources. And then finally, to thank the collaborators who you've seen once before, but who contributed all the cases that generated the information that I just shared with you. Thank you very much.
Dr. Sheena Mukkada for this very excellent talk. And now I'll give the floor to Dr. Sullivan to introduce our last speaker.
Thank you very much. Our final presenter is Dr. Pernilla Pergert. Dr. Pergert is a pediatric clinical nurse specialist and certified pediatric oncology nurse. She is an associate professor and the leader of the Childhood Cancer Healthcare Research Group at Karolinska Institute in Stockholm, Sweden. Her primary research focuses on intercultural care and clinical ethics. She also coordinates a national advanced level education program in pediatric oncology nursing and is part of the management team of a Nordic educational program facilitating team-based ethics case reflection rounds. Dr. Pergert is a member of the Nursing Steering Committee and is the liaison to the Scientific Committee. She is also part of the My Child Matters Nursing Task Force and a member of the nurse specialists of the WHO Global Initiative for Childhood Cancer. Dr. Pergert.
Thank you, Courtney. It's a pleasure to be here on this session, and I'm just going to start to share my presentation, so bear with me. Okay, so I hope that you can see the presentation now. So I'm happy to present on the topic moral distress among healthcare professionals. And my research position is funded by the Swedish Childhood Cancer Fund, but other than that, I have nothing to disclose. And this is the outline of the presentation. So I will give some definitions. I will talk briefly about measuring moral distress. I will present some results from our research on moral distress in pediatric oncology and touch upon moral distress during the pandemic. And then I will say something about consequences of moral distress, and finally, what to do. So there are many interrelated concepts, and for each of them, many different definitions. However, I will focus this presentation on moral distress, and I will just start by giving a brief introduction to moral sensitivity. So moral sensitivity is an attention to the moral values involved in a situation and a self-awareness of your own role and responsibility in that situation. And the term moral distress was first presented in 1984 by philosopher Andrew Jameson. And moral distress has been described as emotional pain and anguish when healthcare professionals know what they think is morally right to do, but cannot act accordingly due to institutional or other constraints. Or when they do not know what to do, what is morally right to do, but must make a decision regardless of the consequences. So moral distress is not the same as work-related stress or emotional distress. It is about being prevented from acting in accordance with your own values and what you think is right. So you act in a manner contrary to your personal and professional values, which might undermine your integrity. So moral distress is part of our practice, but it is highly subjective. For example, to withdraw treatment with curative intention might cause moral distress to one person, while continuing this very same treatment might cause moral distress to another who perceive it as futile. So it all depends on your values. So Hamrick et al. Categorized root causes of moral distress to external constraints. So for example, inadequate staffing or increased turnover or hierarchies within the healthcare system, stopping you from doing what you think is right. Or internal constraints, for example, perceived powerlessness, or self-doubt, or inability to identify ethical issues. And finally, clinical situations causing moral distress without defining what is the constraint. So there are many tools for measuring moral distress and also the various interrelated concepts. The moral distress scale is one of the most commonly used questionnaires for measuring moral distress in specific situations. So rather than measuring symptoms of moral distress, and it was developed to measure moral distress among nurses in hospital settings. And when it was revised, it was shortened and includes 21 items, describes situations found to generate moral distress, and a pediatric version was developed for nurses, medical doctors, and others. So we translated and culturally adapted the MDSR to fit registered nurses, medical doctors, and nursing assistants in Swedish Pediatric Oncology. And the cognitive interviews regarding the Swedish MDSR revealed that the original 21 items were found to be relevant, but we also identified 5 not captured situations. So the Swedish MDSR includes 26 items. And it has also been translated to Finnish, Danish, Icelandic, and Norwegian. So in the MDSR, the respondents are asked to indicate on a Likert type scale ranging from 0 to 4, both intensity score, so how would this situation affect you? Not at all or very negatively. And a frequency score, how often have you experienced this situation? Never or too very often. And a moral distress score can be calculated by multiplying the intensity score and the frequency score for each item. Yes. So now I move on to moral distress in pediatric oncology. And we have performed some studies, and I will present the results from these studies. So this is a table from the national study in Swedish Pediatric Oncology with 278 responding healthcare professionals. And it shows the items with the highest moral distress score and the top ranked item per professional group. So the 2 situations that had the highest moral distress score was related to an external constraints. So to work in a staffing situation that you experience as unsafe, and to see that the healthcare of the patient suffers because of lack of continuity with many different healthcare providers. Now this figure shows the mean moral distress score per professional group for the same 2 items. And you can see that registered nurses reported higher moral distress scores on both the situations. So this was related to higher frequency scores. And that means that they had experienced these situations more often than the others. And this is a table from a study with 93 nurses in pediatric oncology in Finland, presenting the frequency and the intensity score. So here you can see that the two same situations are a bit further down on the list because they didn't happen that often. However, when the situation happened, they were quite disturbing, as shown by the intensity score. If you remember, the max score was 4, and here you have 3.55 and 3.03 for the intensity score. Here are 2 items about competence. First one is to work with healthcare professionals who are not as competent as a child's healthcare requires. And this was ranked as 4 by registered nurses and nursing assistants and 7 by physicians. And then to be expected to care for patients whom you do not feel competent to care for. And as you can see, this was ranked as number 6 of all the 26 items by registered nursing and nursing assistants, but not by physicians. Another situation that was generating high levels of moral distress was to see that the quality of the patient care suffers because of poor communication within the team. And it was ranked as the 3rd most morally distressing situation by registered nurses and 4th by physicians. This figure shows the mean moral distress score per professional group again, and on the item colleagues lacking competence and poor communication within the team. And you can see that registered nurses reported higher moral distress scores on both of these situations. And this is the table from the Finnish study again, presenting the frequency and the intensity scores. And the second most common situation was not having time to conduct conversations with patients and families in a way that you think these should be carried out. And here is the mean moral distress score per professional group for that same item. And you can see that registered nurses rated the highest score. And so the intensity score was moderate or high for all professional groups, and frequency was high also among all the professional groups. So this situation happened often. I will try to relate the results to the situation during the pandemic, although we have not studied moral distress during the pandemic. So if we go back to some of the situations generating moral distress in pediatric oncology, 2 was related to unsafe staffing and lack of continuity. And if you remember from the Finnish study, these 2 situations did not happen that often. However, when the situations happened, they were experienced as quite disturbing. Thus, it is likely that during the pandemic, these situations would be even more morally distressing because they would be more frequent, related to additionally limited resources and the need for strict prioritization. 2 other situations were about colleagues and your own lack of competence to care for the child. And during the pandemic, there were no or limited scientific knowledge to lean on, and constantly conflicting messages of what would be the right action. So we all needed to learn about the disease and did not have the knowledge and competence needed, which definitely could stop us from acting according to our moral values and what we think is morally right, and thus could cause moral distress. 2 of the situations were related to communication, one within the team and one with patients and families. And during the pandemic, communication was hampered not only by time, but also by the professional protective equipment covering the face, and maybe also fear of becoming infected yourself. So it is not easy to have the first conversation with a family about the child's cancer diagnosis or to build relationships with the sick children behind the mask. So now we're moving on to consequences of moral distress. So symptoms of moral distress vary and may include emotional, physical, and psychological symptoms. And some of the consequences of moral distress for healthcare professionals have been found to be frustration, decreased self-confidence, powerlessness, burnout, and lack of job satisfaction, which in turn can lead to bitterness, anger, irritation, and cynicism towards colleagues, patients, and parents, increased turnover of healthcare professionals, and ultimately diminished quality of care of the children and their families. So, are there any positive consequences of moral distress? Some would argue that there are. Moral distress could be a sign of moral sensitivity. So, situations that generate moral distress will occur in all healthcare settings. So if there is no moral distress, it might be that there is no attention to the moral values involved in the situation. In the study by Prentice, moral distress was viewed as an essential component of the caring profession because it stimulates discussion and motivates decision-making. It also can serve as a positive catalyst in exercising moral agency. That is, to develop moral strength, to act on your conviction and in accordance to your values. So it's similar to any other distress and worry because it can make us act. So in summary, what can happen is that you can decide to leave the workplace to escape moral distress, or you can continue to experience moral distress, and this might build up and lead to burnout. Or your moral sensitivity can decrease, so you become numb. So either you stop paying attention to the moral values involved in the situation, or you stop seeing your own role and responsibility in the situation. Or you can act and initiate a change to your desire in order to do what you think is needed and to identify the values and possible courses of actions. So if we want to act, what can we do? I would like to start by talking a little bit about ethical climate. So according to Linda Olson, the ethical climate is perceptions of organizational conditions and practices having to do with the way difficult patient care problems, which have ethical implications, are discussed and decided in the work setting. So moral distress have been found to be correlated with perceptions of the ethical climate. In the study by Sullivan showed that the more positive the ethical climate was perceived to be, the less frequently moral distressing situations were reported. Also in the Finnish study, we could see a significant correlation between the perceptions of the ethical climate and moral distress frequencies. So the ethical climate definitely seemed to be important and is something that we should prioritize. So when we want to act, I do not think that it should be up to each individual professional, even though moral courage is important. I rather think that the clinical ethics support services should be provided. And the aim of clinical ethics support services is to support healthcare professionals, patients, and their families when faced with ethical issues. And one form of ethics support is ethics case reflection rounds developed in order to help healthcare professionals reflect to deal with ethical issues in care. And this is a meeting where the relevant stakeholders, for example, the interprofessional healthcare team, reflect on specific ethical issues in a patient case. And often there is a trained facilitator who guides a dialogue using a structured method. And there are different kinds of structured methods to guide the dialogue, but usually they include these steps. So there should be a case presentation, including facts such as medical facts, nursing facts, legal facts, cultural facts, and so on. And formulating of the moral question or the dilemma, and then identifying values and possible courses of actions, and the conclusion and how to do it right. So many of these structured methods are published and available, and you can see some references at the bottom of this slide. However, the most important message is that we need to reflect on our values and our practices. In the United States, the American Association of Critical Care Nurses have developed a tool for recognizing and addressing moral distress. And it includes 5 steps to identify what you're experiencing. Is it moral distress or something else? So is there a moral aspect? And assess your level of moral distress. And there are several scales to measure these symptoms. However, I would argue that it is impossible to know if the symptoms are related to moral distress, to work-related stress, or even stress in your private life. And then identify cause and constraints, and identify the specific situations that trigger moral distress, and if the constraints are related to internal or external factors. And this is, of course, important. We can do yoga, mindfulness, and meditation, but if the constraints are not internal, but rather organizational, the changes need to be made in the organization. And select resources that can help. So choose strategies to address moral distress based on the type of constraint. And finally, identify moral distress resources and strategies available to you at your workplace. So this is a tool that is available freely online. So in conclusion, moral distress is a natural part of our practice. We need to take it seriously because the consequences are devastating for healthcare professionals, organizations, patients, and families. And it should not be up to the individual healthcare professional to deal with moral distress, but rather clinical ethics support services should be provided because it can help healthcare professionals to deal with ethical issues and moral distress. And with that, I would like to thank you and also say thank you to my co-researchers, Margareta Sandberg and Päivi Ventovaara.
Thank you so much, Dr. Pernilla Pergert, for this excellent talk. And now we will take the questions and we can go on with the discussion. Dr. Sullivan, would you like to take the 2 questions that were asked?
Yes, and we have just a few minutes now for questions, about 7 minutes until the end of the session. So if you have questions, please type them in the chat and we will do our best to have our esteemed speakers address them. So we have a couple of questions for Dr. Tubbs-Cooley about how do parents and families, their presence at the bedside positively and or negatively impact reliable care?
I was glad to see this question asked. We don't have a lot of data on this that's published, but I think it's a really critical question in the time of COVID with visitor restrictions, right? I think this can potentially go both ways. I will tell you, in our study, we do ask nurses to report on whether parents are present. We are going to be looking at parent presence and how that impacts missed care during a shift. But we do see in our comments from both our prior studies and currently that parent presence at the bedside can be helpful, but it can also add to workload as well, depending on the situation. So, if you're really dealing with a new family or a social situation that's difficult and families are at the bedside, sometimes that adds more stress to nurses and adds to the workload. And sometimes it's actually really helpful, especially when staffing is tight. Sometimes parents, of course, you want to engage them and make sure that they're engaged in care, but sometimes, having parents there is really how care is getting delivered, and engaging parents in that process can be really a tool for nurses, and not just a tool, but like, how we should be delivering care anyway. So I think it can go both ways depending on the context.
Thank you. And then another question, how can one compensate for managerial errors that might affect nursing care and eventually lead to nursing mistakes? And I think, if you could address this, Dr. Tubbs-Cooley, and then I think it also kind of ties into what all of the speakers, were talking about a little bit, as far as, the processes, the workflows, all of the changes in care delivery, some change management principles that may impact how care is delivered and the stress on nurses, care providers, and patient outcomes.
Yeah, I saw that question come through, and I think it's really a challenge. If we were in person, I would ask for more clarity on like what a managerial error and what that means. But I will say, I think that I want to recognize that I think managers of all types, not just nurse managers, but our administrators of all types are also really having a difficult time with this and are doing their best to manage resources, I think, in the best possible way. So I think everyone is in a tight spot, but when it's clear that workload is not being managed well, I think, it's really difficult, right? Because it becomes almost a downward spiral in some units. Workload is not managed well, miscarriage is happening, people are experiencing moral distress, and then we start seeing, a spiraling of turnover. And so, I think, nurses and other clinicians advocating as best they can. Hopefully there's a culture within the organization that empowers people to speak up, empowers people to be able to bring up concerns without penalty. A just culture is really important. But it is a hard one, and especially right now, it's difficult for administrators to materialize human resources out of thin air. And so I think that's where organizations really are going to have to get serious about thinking, their compensation packages and making sure that people want to stay in their environment. It's not just compensation, of course, but getting serious about retention for frontline staff is critical.
Thank you. Dr. Sheena Mukkada, maybe we can, I would like to take your comment on the COVID-19 situation in the cohort of the St. Jude. Sheena, you're here, right? And on the cohort of the St. Jude Global Registry, the complications were seen more in low and middle income countries, as you have shown that according to the World Bank classification. Could that be because of the supportive care, since we do not have a specific treatment nowadays still for COVID-19, the supportive care, as in other febrile neutropenia and in other subjects, is so important. The lack of supportive care, could that be also one of the reasons for having complications more in low and middle income countries? Again, emphasizing the role of supportive care, which is one of the major topics of today.
That is absolutely one of the hypotheses. It probably has to do with a combination of system changes, right? Because there's the healthcare systems that are the most fragile that are then having to absorb these patients, and that's the part that everyone here is just talking about, and think about all of the missed opportunities, right? And everything kind of aligning in that way. And that burden is probably exaggerated in lower and middle income countries. And then also there may be the aspect of delayed diagnosis that may be superimposed upon this too, because it depends when children can actually come in and be seen, and are they sicker when they end up coming into that institution.
Thank you so much. And for Dr. Pernilla Pergert, it was really a very important topic, the moral distress. One point that you emphasized was so important, that because of the work overload, especially during the pandemic, time to talk with the parents and the caregivers is so short. You have emphasized that, but would you like to comment on that?
No, I think it's also really connected to missed care that Heather was talking about, that this is something that is not in accordance with our moral values. It's so important. We know the importance of communication and creating relationships, and when it's not possible, this is we're not happy with the work that we're doing.
Yeah, but still, everyone has tried to do the best during the pandemic, yeah. Right? We have a lot of thanks for to all speakers for their thoughtful presentations from Laura Linder and many other participants. Thank you for the great session. So I'm delivering their thanks to all our speakers. Yes, Dr. Sullivan, would you like to comment on any of these talks? Any questions?
Yeah, I mean, I think I would also just like to thank the speakers and just reiterate what you said. I think it's a really important time for us all. When we're thinking about disruptions in care due to COVID-19 in the healthcare workforce, the external, internal stressors, the relational stressors. I think, one of the themes that Dr. Tubbs-Cooley talked about a little bit was resilience and support for one another. And as we're providing supportive care for our patients and families, doing that with compassionate caregiving. So I think, that's something that, is a theme that I think came out of this, is for all of us to take away as we're dealing with these stressors that impact our care, just to take care of ourselves and to really be compassionate towards one another so that we can give compassionate care to our patients and families. So thank you again for all of your expertise and your valuable contributions to this session.
Well, so with this, before ending our session, both me and my co-chair, Dr. Sullivan, would like to thank all of our speakers for their excellent talks, to all the participants for being here with us and for their very valuable questions and comments. And also, we would like to thank all the healthcare professionals that have worked so hard all over the world during the pandemic, with in many places with very low resources, and even in high resources, because everyone has faced the difficulty. So a big applause to our healthcare professionals all over the world. And we want the best for our children with cancer. So thank you.
Advocating as best they can. Hopefully there is a culture within the organization that empowers people to speak up, empowers people to be able to bring up concerns without penalty. A just culture is really important. But it is a hard one, and especially right now, I mean, it's difficult for administrators to materialize human resources out of thin air. And so I think that's where organizations really are going to have to get serious about thinking, their compensation packages and making sure that people want to stay in their environment. It's not just compensation, of course, but getting serious about retention for frontline staff is critical.
Thank you, Dr. Sheena Mukkada. Maybe we can. I would like to take your comment on the COVID-19 situation in the cohort of the St. Jude. Sheena, you're here, right? And on the cohort of the St. Jude Global Registry, the complications were seen more in low and middle income countries, as you have shown that according to World Bank classification. Could that be because of the supportive care, since we do not have a specific treatment nowadays still for COVID-19, the supportive care, as in other febrile neutropenia and in other subjects, is so important. The lack of supportive care, could that be also one of the reasons for having complications more in low and middle income countries? Again, emphasizing the role of supportive care, which is one of the major topics of today.
That is absolutely one of the hypotheses. It probably has to do with a combination of system changes, right? Because there's the healthcare systems that are the most fragile that are then having to absorb these patients. And that's the part that everyone here is just talking about, and think about all of the missed opportunities, right? And everything kind of aligning in that way. And that burden is probably exaggerated in lower and middle income countries. And then also there may be the aspect of delayed diagnosis that may be superimposed upon this too, because it depends when children can actually come in and be seen, and are they sicker when they end up coming into that institution.
Thank you so much. And for Dr. Pernilla Pergert, it was really a very important topic, the moral distress. One point that you emphasized was so important, that because of the work overload, especially during the pandemic, time to talk with the parents and the caregivers is so short. You have emphasized that, but would you like to comment on that?
No, I think it's also really connected to missed care that Heather was talking about, that this is something that is not in accordance with our moral values. It's so important that we know the importance of communication and creating relationships, and when it's not possible, this is we're not happy with the work that we're doing.
Yeah, but still, everyone has tried to do the best during the pandemic, yeah. Right? We have a lot of thanks for to all speakers for their thoughtful presentations from Laura Linder and many other participants. Thank you for the great session. So I'm delivering their thanks to all our speakers. Yes, Dr. Sullivan, would you like to comment on any of these talks? Any questions?
Yeah, I mean, I think I would also just like to thank the speakers and just reiterate what you said. I think it's a really important time for us all. When we're thinking about disruptions in care due to COVID-19 in the healthcare workforce, the external, internal stressors, the relational stressors. I think, one of the themes that Dr. Tubbs Cooley talked about a little bit was resilience and support for one another. And as we're providing supportive care for our patients and families, doing that with compassionate caregiving. So I think, that's something that, is a theme that I think came out of this, is for all of us to take away as we're dealing with these stressors that impact our care, just to take care of ourselves and to really be compassionate towards one another so that we can give compassionate care to our patients and families. So thank you again for all of your expertise and your valuable contributions to this session.
Well, so with this, before ending our session, both me and my co-chair, Dr. Sullivan, would like to thank all of our speakers for their excellent talks, to all the participants for being here with us and for their very valuable questions and comments. And also, we would like to thank all the healthcare professionals that have worked so hard all over the world during the pandemic, with in many places with very low resources, and even in high resources, because everyone has faced the difficulty. So a big applause to our healthcare professionals all over the world. And we want the best for our children with cancer. So thank you.